Well, welcome everyone. Glad to be with you again. I'm very pleased to have another guest professor joining us this morning. And I see from the list that we have representatives from Southeast Asia and probably the Middle East and other areas as well. So we're truly an international gathering of pathology learners and teachers this morning. I'd like to introduce our guest professor this morning, Dr. Sepeda Asadbiegi, or Nikki as we refer to her, joined our faculty a few years ago after having both completed her residency in our program and then following that on with a fellowship in dermatopathology at Northwestern University in Chicago. She originally hails from Iran, where she completed her graduate medical studies prior to immigrating to the United States. And she is now the mother of one delightful daughter, who is the apple of her eye. But she won't be talking about that too much, so I will allow her to share her screen and let you take it away from here, Nikki.
Thank you so much, Dr. Hassel. Actually, you may hear her in the background. I apologize for that already. Um, but let me share my screen. Okay.
You're muted, Nikki.
I apologize. Give me 1 second. Okay. Can you see me now? Can you see the screen now?
Yes.
Okay, perfect. Thank you. So these are the cases that we don't see them very often, but when we see them, it's going to be a challenge for many of us. Even dermatopathologists are going to have challenges with them. Some of them are more common, some of them are less common. Most of them are going to be in the younger population, not necessarily children, but in the population that's like not elderly population. In the population, older population, we mostly see if we're having malignant or atypical melanocytic proliferation, it's usually the melanoma, which are related to the sun exposure, but these ones are the ones that are usually having different kinds of mutation or fusions with them. So the first one we're looking at is probably someone around 20-year-old. They're having a lesion on, let's say, extremities. It's kind of darker and then they just want to check it out. So when we're looking at it, we're having something like a punch. Biopsy here, in many of these cases, actually, you can see that the dermatologist who did the biopsy, they did a shave first, and then they go and do the punch, and we're going to say why they're going to do that. In the epidermis, which is the first thing we usually evaluate in the assessment of the skin, we're not seeing anything. In the dermis, I don't see a lot of activity here. And that's one of the main things we want to check. Is it a crowded dermis? Is it not a crowded dermis? This one is not a very crowded dermis, but even in low power, I'm seeing maybe something is going on here. So when we go higher power, we can see we're having some pigmentation. Pigmentations in the skin, there are usually kind of three types of different pigmentation. It can be melanin pigmentation, which is the one the first thing we think about. We can have hemosiderin pigmentation because of the old hemorrhage we're having in the skin, and we can have the external pigmentation such as tattoo. And it's very funny because depending on the color of the tattoo you're having, actually in the skin we can see different colors of pigments. For this one we're having something kind of brownish blackish pigmentation, and it's kind of coarse pigmentation, so it's more like a pigmentation we see with the melanin, not with hemosiderin, even though that we can stain it and we can see which one we're having. For example, if you're staining with iron, if it's hemosiderin, it's going to be bluish. So we're having pigmentation, but we can have pigmentation and pigment drop. Let's see if we're having something else. The other things we're having here are these melanocytes, which are not very clear, like very big here. They're kind of dendritic, and these dendritic melanocytes are the ones that are making this entity. So we're having dendritic melanocytes among the dermis, and that's something we see in blue nevus. So let's go here. We can see a little more collection of these cells. Very like tiny melanocytes with the pigments, and not in all the cases are going to have pigment. In most of the cases, we're going to see pigments, but there's some amelanotic blue nevus as well. So this is an easy diagnosis. If it comes like this, you can stain it with Soxten, and it's going to be like a Christmas tree. It's going to highlight all of these melanocytes, which are pretty tiny. The problem is if they give you a biopsy, which is more superficial like this, then it's going to be much harder to find these cells. Again, they're going to tell you that they're thinking about this. Probably the reason is that they are called blue nevus, and the reason they're called blue nevus because clinically they look blue. The reason we usually see a shave biopsy is that the dermatologist is going to try to shave it off, but then they see the deep pigmentation and they try to do a punch or another deeper shave to take the whole lesion out. These lesions, you're not supposed to see any mitosis. If you see mitosis, you can think about other things like desmoplastic melanoma, but usually it's a very easy diagnosis to make. For blue nevus, we're having another type of the blue nevus, which is called cellular blue nevus. Cellular blue nevus, it comes from name. It's pretty blue. It's going to look blue clinically, but then what you're having is a higher number of the cells. In general, blue nevus, whether it's dendritic or cellular, it can have both of the components, but one of the main thing is which one is more? Is the dendritic component more? Or is it a cellular component, which is the main component of this nevus? If the cellular component is the majority of the nevus, then we call it cellular blue nevus. If the dendritic part is the majority of that, then we call it just the usual or dendritic blue nevus. So for the dendritic blue nevus, what we're having here is that we're having the bulbous infiltration deep to the dermis or sometimes the subcutaneous tissue. We're not having infiltration. They can look pretty scary because it's very cellular, it's very pigmented, but these are benign lesions. Again, we can have atypia, we can have melanoma arising from this, but that's very rare. Whenever you're having melanoma arising from this, you're going to have tons of atypia. In the dendritic blue nevus, we're not supposed to have any mitosis, but in this one, you can have up to like 1 or 2 mitosis. The center of the lesion is where you're seeing the melanocytes, that they're not having a lot of pigment. Again, you can see the cytoplasm is kind of bluish, so it doesn't have a lot of pigment. But when you go to the periphery of the lesion, you can see all of the melanophages that they're having the pigment. Usually how these ones work is that they're having one axis, and then these melanocytes are going to go around that axis. That axis can be vertical, it can be horizontal, but usually they hang on that axis. The main mutation these are going to have is GNAC and GNA11, as we can see it in uveal melanoma. Also, there are a couple other mutations that they're having, but those are kind of less frequent. Most of the time, we don't need to do any molecular testing or anything else for these cases. We can do a staining if we need to, but you can see it. You don't need to do tons of staining. One of the things that's important is HMB45. HMB45 is not usually the stain. I use it when I'm assessing for example, the nevite, dysplastic nevus. It doesn't matter that much. But for melanoma, it's important because with the maturation, when we're having maturation, we're supposed to have the loss of a staining. So what happens is, in the normal nevi, we're going to have a lot of staining at the top part of it. When it goes deep, it's going to be the loss of it. In some conditions, we're not going to have the loss of it, such as melanoma. But the other one, which is a benign condition that we're not going to have the loss of it, is the cellular blue nevus. So in the cellular blue nevus, all of the cells are going to stain with HMB45, but it doesn't mean it's melanoma. It's a benign lesion. Okay, let's go to the next one. The next one is it's a very close relationship with the blue nevus. You can see they're kind of very similar to each other. If you look at them, low power, this one maybe a little more bluish, this one a little more kind of pinkish and brownish, and both of them they have kind of bulbous or kind of a very broad base. Both of them they can go pretty deep, but this one is we call it the pigmented epithelioid melanocytoma, which is a kind of a newer entity that we used before. They were calling it epithelioid blue nevus, or they were calling it an animal type melanoma, which is a term that I usually don't recommend using it, especially in the reports. The patients are not going to like reading something like that. So for this one, what we're having is we're having a lesion which could be connected to the epidermis, or it could be completely intraepidermal. In about 30% of the cases, it's connected to epidermis, but in most of the cases, in the majority of the cases, it's not going to have the connection. We're seeing tons of pigmentations. If we go to the higher power of this, we can see there's a more cellularity in the center of the lesion, and because we're having more cellularity, we're going to have more of these like epithelioid or spindle cell melanocytes. But when we go to the periphery, we're going to see less of the epithelioid or the melanocytes, which are having more cytoplasm, and then we're going to have melanocytes that more spindle type melanocytes. We're also having more of the pigmentation, which are the melanophages. This is another lesion. Looks very scary, but these are benign lesions. They're usually actually there is no one dying from these lesions. These are not melanomas. How do we make the diagnosis? And my diagnosis is mainly based on the histologic findings. Again, you're having the epithelioid melanocytes mostly in the center, but you're going to also have a mixture of dendritic melanocytes, which is mostly in the periphery, and then you're having tons of pigmentations. They're going to go deep, but they're not having infiltrative pattern, very infiltrative pattern. They're having the bulbous pattern, so which is kind of a little well circumscribed. These ones are having their own mutation. The mutation can be a combined mutation. You can have the BRAF mutation with other mutation, which is going to be mostly PRKA R15, which is also a stain. We can use it. If we use that stain in the normal nevus, it's going to have the retention. In the PEM, we're not going to have retention. We're going to have loss of it. And based on those mutations, you can say if this is a benign, if it's like a PEM or not. But again, you don't need to do microarray in these cases. In rare cases, you can have melanoma arising from them. If you're having melanoma arising, then you're going to have a brisk mitotic activity. And mitotic activity is something that I really like to check for these cases, which are pretty challenging based on the histologic findings. Again, this one can have up to 2 mitoses per high power field, but if you're having more than that, if you're having tons of atypical mitosis, and that's the time you want to check it. Usually we do microarray for these ones, but once in a while I also send them for the fusion, for the sequencing, because I want to see if they have third promoter mutation, because if they're having that, then I'm going to think about melanoma. If it's pure PEM, it's not going to be malignant, it's not going to kill anyone, but once in a while we can have melanoma arising from these ones. Let's go to the next one. Next one is one of my favorite. The reason for that is I do a lot of pediatric germ, and I see that in the pediatric population. This is something that if like you're new in pathology, you don't have a lot of derm path cases, it can scare you a lot. But usually after a few of the cases that you see, it's a very similar pattern that they're following, so it gets easier to make the diagnosis. When you're looking at this in the low power, you can see a lesion which is having a very sharp start, very sharp end, and that's one of the main characteristic of this lesion. In melanoma, in like dysplastic nevus, we're not having well circumscription. In these lesions, we're having a sharp start and a sharp end. Let's go low, higher power, see what else we're having. The thing is, if I put a line here, do we have a symmetrical lesion or not? Symmetrical lesion depends on a lot about how they did the biopsy, but in something, for example, if they do the biopsy from here, it's not going to be symmetrical. But in these lesions that you can see the start and the end of it, you can just count on the symmetrical or non-symmetrical lesion based on what you're seeing in this biopsy a lot. So if I put a line here, the right half and the left half are going to look pretty the same. So that's a good sign. Let's go on higher power. What we're seeing some melanocytes, which are kind of, they're hanging. See, they're hanging here. So that's one of the other features we're having. We're having some communobodies, which are these pinkish cells. We're having clefting. All of these are clefting, okay? They can look like kind of a scary a little bit because they have nucleoli. They're like bigger. But this is a benign lesion. Some of them are bigger melanocytes, but it's totally normal to see larger melanocyte in this lesion. This is called a Spitz nevus. Again, we are having communobodies. Some of the communobodies, they can be larger, which is better. Maybe this is a communo, maybe not. The other thing we're having is pagetosis. Usually when we talk about pagetosis, we think, oh, melanoma. But in this lesion and a few other lesions that we're going to talk about, we can have pagetosis. The pagetosis is usually in the center of the lesion. If you're having pagetosis on the periphery of the lesion, you can think about atypical Spitz tumor. And usually for the pagetosis and upward scatter, we don't want it to go more than the upper half of the epidermis. So you're having a lesion with clefting, with sharp start and end, with hanging. It's like hanging bananas. A little bit of pagetosis, but you're not having a lot of atypia. Maybe you're having a little bit of inflammatory response. So this is a benign Spitz nevus. And it usually happens in the pediatric population. It's usually in the extremities. It can be on trunk. Sometimes it's on the face. Usually they grow pretty fast. The reason they come to you because the parents said this is a lesion which is growing pretty fast. But if they don't do anything to it after 2 or 3 months, it's going to stabilize and it's not going to grow after that. But the main thing is that these lesions can be benign, but we're having atypical Spitz tumor. We also have a Spitz melanoma. And the thing is, these ones that if we're having this Spitz, atypical Spitz tumor or melanoma, we're going to have more atypia. We're going to have more mitosis. We can kind of have ulceration here. In this one, we're not having it. But if you go higher power, you can see these cells are much bigger than the other ones that we were having. The other ones, they were kind of large, but they were spindly. They still had some maturation, but this one, there is is no maturation, which means that if I'm having a melanocytes here, and if I'm having a melanocytes in the deeper dermis, they're showing the same size. So there is no maturation here. And you're supposed to have maturation in the spits. In blue nevus, cellular blue nevus, you are not having maturation. But in these ones, you're supposed to have maturation. And then when you go higher power, these are usually having more than 2 mitoses. It's between 2 to 6. If you're having more than 6, we usually think about a Spitz melanoma. But you can see here the nuclear border is irregular. You can see tons of nucleoli, even though we can see it in the benign Spitz. But these irregular nuclei and these large cells, see how large these ones are? These are atypical. We can see in this one how much large the nuclei is and how much pleomorphism you're having. In these ones, you're having a more of infiltrative border here. You can have the infiltration of the lymphocytes, much more infiltration of the lymphocytes around it. So for Spitz nevus or Spitz, atypical Spitz tumor or Spitz melanoma, if it's a Spitz, it's supposed to have some certain mutation. It's going to be HRAS mutation, or it's going to be the kinase family fusion. And to call something a Spitz, we have to have either this mutation or the fusion. If we are not having it, we cannot call it a Spitz anymore. They can look like a Spitz, but they're going to be called a Spitzoid. It's not going to be a Spitz. For a Spitz, you're supposed to have mutation or fusion. And that's very important because the Spitz family, the prognosis of it is different than a Spitzoid family. If you're having a Spitz melanoma during the childhood, the prognosis of it is going to be much better, even if the sentinel lymph node is involved, that many of people such as Dr. Garami, who was my mentor, and he was an amazing dermatologist and dermatopathologist, didn't believe in any further treatment. But if you're having a Spitzoid melanoma, which is happening especially in the adult population, the prognosis of it is going to be much more, and you probably want to give them treatment. So because of that, it's very important. The criteria for this is also both histologic but also molecular. For a Spitz, it's something that for blue nevus, I never send it for molecular. For a Spitz, it's something that if I'm seeing anything that I'm thinking about atypia, I send it for microarray, because if I'm having more than 2 findings of microarray, then I'm going to call it atypical. Or sometimes I send it to sequencing, because if I'm having third mutation, then I'm going to think about melanoma or a Spitz melanoma in those cases. So for these ones, if you're having atypia more than normal, such as increasing mitosis, such as that you're having lack of maturation, such as that a P16 loss, which is indicative of in some cases that you're having like mutation or not, and it makes it a little more thinking about, okay, we're having P16 loss, then you're thinking about more atypia or maybe melanoma. In those cases, you need to send this for molecular, because molecular is going to be very important in these cases. The main I see that I use for this one is going to be, I do SOX, I do HMB45. HMB45, you're going to have the gradual loss of it. So if you're not having the gradual loss of it, you're going to think about probably a more atypical process. I do Ki67, even though Ki67, because of all of these lymphocytes that you're seeing here, it could be falsely like kind of increased, which is in real life it's not that much, because what we care is if it's increased in the melanocytes or not. I do P16 for sure. For PRAME in a Spitz, it's something that it's a little like you don't know how much you can count on it. I love PRAME for melanoma, but for pediatric lesion and a Spitz, it's hard to interpret that. And because you can see it in something which is, you can see it positive in something which is very proliferative, and a Spitz is a proliferative lesion. Let's go to the next one. And next one, it belongs to the same family. As you can see, it's a punch biopsy, which means it's probably a small lesion. If you have these biopsies, it's usually in the extremities, lower extremities of a young female, and it was a very kind of dark lesion. You can see in this one also, you can have a sharp start and a stop, and you can see the like the middle portion we're having of bigger nest. In the portion that we're having closer to the edges of the lesion, we're having a smaller nest, but we're having kind of sharp start and a stop. If you put a line in the middle of the lesion, it's pretty symmetrical. Let's go on a higher power and see what we're having. We're having a spindle cells, again, a spindle melanocytes that are hanging. Also, they're looking kind of a little bit of um, with a clefting here, which is what we see in this lesion. We have cleftings like a spitz. We can have communobodies, not necessarily you're going to have communobodies in all of the cases. And then we're going to have a spindle-shaped melanocyte. They're spindle-shaped, but they have kind of a good amount of cytoplasm and tons of pigmentation in the dermis. Even though the lesion is not very deep and it's probably mostly like junctional, but you still have tons of pigmentation in the dermis. This is called pigmented spindle cell nevus of Reed, which belongs to the kind of the with the Spitz family. They are the same things, are brothers with each other. For the pigmented spindle cells, we have the Reed type, which is this one, which is pretty like kind of pigmented. Most of the time, it's kind of junctional. If it's not junctional, it's going to be if it's compound, it's going to be pretty superficial in the superficial dermis. You can have a typical component of it, which means that the the pagetosis that usually you're having in the middle section of the epidermis, middle section of the lesion, which is in the lower half of the epidermis, is going to be in the periphery as well, and then you're going to have much more of the pagetosis, atypia, probably mitosis. So you can have a typical component of it. In this family, we're having the plexiform pigmented spindle cell nevus, which in that one, what you're seeing is that you're going to around the neurovascular like plexus, that you're going to have a spindle shaped melanocytes. That one can be a differential diagnosis with deep penetrating nevus or blue nevus, but plexiform a spindle pigment, a spindle cell nevus is just like it's much less crowded than a blue nevus or deep penetrating nevus. Again, these are benign things. You can have atypical that you want to excise it, and in some cases, in very rare cases, we can have melanoma arising from this, but that's very rare. If you're making the diagnosis of Reed, if you get to make the diagnosis of Reed, you know this is a benign entity. Again, they look like a spitz. They're mostly pigmented if you want to make it easy. The other one, which is not very common, is a combined nevus. For combined nevus, it comes from the name. You're having two populations. The BAP family nevi, for example, the BAP1 combined nevus also belongs to this family. In BAP1, what happens that BAP is expressed in all of the cells. If you're having the loss of it, we're going to have two different entities. We're going to have the combined BAP nevus, which is going to be usually a pretty like normal congenital like type nevus, acquired type nevus, which are having a small nevomelanocytes, no atypia. It's usually it's around the hair follicle. It's the same pattern, but that we usually see in the acquired nevi or congenital nevi. But then you're going to have another population of it. This one is a combined nevus of the normal nevomelanocytes, and this one is probably a DPN or deep penetrating nevus. The reason I'm showing that is that these are the things that you can think, oh, is it melanoma arising from the just nevus? No, these are combined nevus. These are going to be two different pattern, two different entities happening at the same time. It could be kind of collision pattern, or it could be that we're having something, we're having the second mutation to it, for example, DPN, that you're having beta-catenin mutation. Or for example, in some of the BAP ones, the combined BAP one, you're having BRAF mutation, which is the most common mutation in the normal nevi, acquired nevi, and then you're going to have BAP mutation on top of that. So what happens in both of it, for example, if it was a combined BAP mutation, you could have BRAF in all of them, and then you're going to have the BAP loss in this component of the nevus, and you would have the retention of BAP in this one. And that's the reason I put this one. Not all of the cases that you're having two population is going to be malignant, but in many of the cases that you can have melanoma arising from a nevus. So it's important to know about these lesions. The combination can be any combination. It can be a Spitz acquired nevus. It can be blue nevus acquired nevus. It could be just a Spitz, a BAP. It could be anything. So you can have any combination for these ones. For the next lesion that we're seeing, we're having something that is not very common, but if it happens, it's going to be a lot of challenge for the person who is reading that slide. What we're having here, not a lot of changes in the epidermis again. What we're having is most of the activity in the dermis. We're having the collagen around a population of cells, which are kind of looking a spindle shaped. But some of them, you know how we had the blue nevus, it was more wavy. This is not maybe as wavy as that one. Some of them, they're kind of a little round, they're having a little more cytoplasm. But the main thing we're having here is the sclerotic desmoplastic dermis around these melanocytes. This is a desmoplastic Spitz nevus. This is very scary because it can be in differential diagnosis with desmoplastic melanoma. How do we differentiate that? For this one, you're not supposed to have atypia. For desmoplastic melanoma, you're having atypia, you're having mitosis. Okay, if the histology is not that helpful, if the histology you're struggling, what else can you do to help yourself? You can do IHC. These ones are going to be, it's a possibility that they're going to be HMB45 positive, but for desmoplastic melanoma, you usually don't have HMB45 positivity. They're only having SOX10 and S100 positivity. You can do KR67 in this one, because KR67 you don't have a lot of inflammatory response. In the desmoplastic Spitz, it's not supposed to be high. If it's high, then you're going to think about desmoplastic melanoma, and at the end you can send this for microarray and do the sequencing on this one. But for these ones, they're usually scary, but usually the stroma is more desmoplastic, is more reddish, and then you're not going to have atypia, you're not going to find mitosis in desmoplastic Spitz, which is going to be very helpful. Sometimes in desmoplastic melanoma, you're having the junctional component that's going to be very helpful if you see that one, but not in all cases of desmoplastic melanoma that I saw that I had the junctional component to it. Again, if you're having junctional Spitz, it's also going to be very helpful, but again, not in all the cases you're going to have this one. Let's go to the next one. Next one is one of my favorite because I see it a lot. And usually when the residents are seeing it, they always call it melanoma and they're really scared about it. And when I talk to them, I say it's completely benign. You don't need to do anything about it. This is a special side nevus. The special side nevus is we're having in some certain sites. We can have it in a scalp or an ear. We have it on breast, genital area, even though sometimes the genital area, they call it the genital nevi. And in practice, what I saw that in knee, in the flexor side of the knee or elbow, actually we can see these ones happening. These ones can show atypia that we usually see in dysplastic nevi, but in these nevi, because of the site they're on, It's not going to be considered dysplastic or atypical. This dysplasia or atypia can happen because of hormonal changes, such as the ones that hormonal effect that we're having on the breast area or the genital area, or it could be because of trauma. For example, on knee, we're going to have trauma. Let's go on higher power, see what we're seeing. It's not well circumscribed. We're having kind of crazy amount of, like, we're having a nest here, we're having another nest here. These are not well circumscribed. In a switch, you were seeing in the middle section, we were having bigger, like a bigger nest of melanocytes. In the periphery, we were having less, but you can see in the periphery of this nevus, we're still having large melanocyte. The normal acquired nevus, if you're having a normal acquired nevus, you want to see the nests on the tip of the rete ridges. In these ones, that's not what you see. You can see the nevus, the nest is going between the rete ridges, next to the rete ridges. So this is something that if you see in a nevus, which is on arm, which is on trunk, you're going to call it dysplastic because of that. But here, we're having a much higher threshold for calling that. You can have bridging. You're not supposed to have bridging in the normal nevi. If you see bridging, you're going to call it dysplastic nevus, but here you can have it. The nest can be very large. Usually in the normal acquired nevus, especially in the adult population, you're not going to have nests this big. In the pediatric population, you can have big nests. But in the adult population, you're not supposed to have something this large. And you can see it came pretty high. But again, in the special site nevi, you're going to see that. One of the other things that really helping me when I want to know if it's a special site nevus or not is the space you can see. See these kind of like little spaces between these nevomelanocytes? These spaces are suggestive of these are not having good cohesion to each other. So we're probably dealing with a special site nevus. So again, the special site nevus is benign, and you can see atypia, you can see things that they look like dysplasia, but these are benign nevus. They don't need to do anything. Does it mean that we don't have dysplastic nevi or kind of melanoma rising from these sites? No, we can have all of those things. But the thing is, what we're talking about is that the criteria is going to be much higher for these entities to call it dysplastic or melanoma. Let's go to the last slide. The last slide is a nevus that they took out from the acral site. So the acral nevi is going to be the nevus that we're going to have it out from the soles, from the palms, from kind of fingers around the nail area. And the criteria for calling dysplasia or melanoma in these ones are different. So these melanocytes are allowed to have atypia, are allowed to have a little bit of bridging, are allowed to have some pagetosis. Actually, we're having a term which is called maniac, which is I wrote it down. It's a melanocytic acral nevus with intraepidermal ascent of cells, and they, of course, it's hard to say, so they made it short. They call it maniac. Anytime I'm telling the residents, like, oh, it's a maniac nevus, they just laugh at the name. So in those ones, you're supposed to have pagetosis. So you have pagetosis in the acral nevus. Don't call it melanoma just because you're seeing pagetosis. But the pagetosis is supposed to be in the middle section of the nevus. It's not supposed to be on the periphery part of the nevus. For how we had for speeds that we prefer to be in the lower half of the dermis of pagetosis. For these ones, actually, they can go pretty higher than that, and they're still not going to be melanoma or dysplasia. You're going to have a bigger kind of nest in these ones. It can be junctional, just junctional, but you can have compound. The criteria we're using for acquired nevus, such as shouldering, bridging, all of those things, they don't like apply to these lesions. One of the other things that whenever I see them in other sites of the body, I always think about melanoma. It's a single growth pattern, such as this one. Like you're going to have the single melanocytes, a smaller nest here. Usually, if I see it in somewhere else, I think about melanoma or severely dysplastic nevus. But in the acral sites, you can have those. But if I'm having a lesion that I'm seeing the kind of lentiginous growth of the melanocytes all over, tons of pagetosis in the periphery, especially tons of mitosis or things like that, then that's going to be acral melanoma. Acral melanoma, the melanoma in the nails are one of the most challenging ones. The melanoma in the nail or the nevus in the nail is very challenging, especially if it happens in the pediatric population. By no means I'm any expert in that, and I have a lot of a struggle with that. Dr. Rubin is one of the experts in it, and actually I talked to him a few weeks ago, and he taught me that SOX and Melanate and HMB45s are not very good markers to use when you're assessing the nail for melanocytes, for the density of melanocytes, and MITF is the good marker that you can use for that. Again, for the nail melanocytic lesion, it's a totally different chapter, and so if we ever have another session we can talk about it, but those are very very challenging cases. So I think I'm done with all of these ones. I just go very fast over these. This is the like kind of the dendritic blue nevus. For these ones, you don't need to do anything. For cellular blue nevus, the main thing that they're going to have a kind of a bulbous kind of in the deep section, they're going to have bulbous structure. They're going to have pretty very cellular in the main area. It's going to be not a lot of pigmented, the main melanocytes, and then we're having the melanophages. You're not going to have a lot of maturation, but these are benign nevi, and you can have melanoma rising from these, but these two are benign by themselves. For having pen, which is more of a very scary looking lesions, but they're very pigmented and they're having a benign nature. For these ones, I recommend some sort of molecular. I recommend microarray, and actually, if you have sequencing, it's a good thing. If you don't have it, that's okay too. We're having a spitz. The normal spitz is benign, usually seen in the pediatric population. It can be pretty scary because it can have pagetosis. It's very cellular, but they're having sharp end and a start, and they're not having tons of mitosis, even though you can have mitosis in these ones. You don't need to do any workup for these ones. You can have atypical spitz nevus or a spitz melanoma. For these ones, you need to send them for molecular. Main thing, they have HRAS mutation or they have the kinase fusion pattern. If you don't have those, you cannot call them a spitz. If they look like a spitz, they're a spitzoid. The prognosis of these ones are going to be different. We're having the reed nevus. The reed basically looks like a spitz, but it's going to be much more pigmented than those ones. We're having the combined nevus. The main thing about these, we can have melanoma arising from nevus, but these ones, they can be a combination of two very different entities, and then we're not having atypia. Because we're not having atypia such as tons of mitosis or things like that, we're not going to think this is going to be a melanoma arising from a nevus. We're going to think about a combined nevus. The other entity we were having was the desmoplastic spitz nevus. For desmoplastic spitz nevus, have very sclerotic atypia. If you're having atypia toma, the last two entities that we talked about, it is going to was the a special site nevus, that the criteria for calling this plastic is very different. They're allowed to have bigger nests. They're allowed to have a kind of they're not well circumscribed, and they can have some bridging. But the main thing that you're seeing very large nests, that they're kind of having a space between them. And the last one we talked about, it was the acral nevus, that the threshold for calling something dysplastic or melanoma in these ones are much higher, and you're allowed to have some pagetosis in these cases. So I think we're done with it. So I'm going to stop sharing, and if there is any question, I can answer.
Nikki, that was wonderful. So could you just run through again the areas of where you would make the diagnosis of specialized site nevus?
It's going to be on the breast, on the genital area, in the flexor area, such as like back of the knee, kind of back of the ear, and in the scalp, we can have a special site nevi. They're
Okay.
mostly the nests are much larger, and you can see the melanocytes. The melanocytes are small, but they're having a space between them.
And aside from the Spitzneva, the Spitzoid family of nevi, is there anywhere else where we would see camino bodies?
You can see it in the reed, but most of the communal bodies are going to be in the Spitzoid family. We can see a Spitz family. You can see like a Spitzoid pattern because of some dyskeratotic cells or things like that, melanocyte that they look like that, but the communal body is very specialized to the Spitz family. Again, you can see it in a Spitzoid lesions once in a while. They look like that. But for a Spitz, calling something a Spitz is like the terminology was very complicated. Now everyone almost agree that if you call something a Spitz, you have to have HRAS mutation, or you have to have the kinase like ROS fusion. Otherwise, if you don't have those, if you're having BRAF, you cannot call it a Spitz. That's going to be a Spitzoid if it looks like a Spitz.
Well, this has been very helpful. I haven't had a good update like this for quite some time. And some of the divisions that I previously grouped together has been very helpful for me, and I'm sure for our
Yeah.
listeners as well. Um, Anyone else have any questions they want to bring up? If not, I will wrap things up with a very big thank you to Dr. Asadbiegi, and also note that next month we'll have another guest instructor, which will be a return visit from Dr. Kyle Wright, another great member of our OU team in hematopathology. And so we're looking forward to that. His last session on hematolymphoid lesions in the skin was absolutely phenomenal, and I encourage people to go back and look at that if they have not previously seen it. So, Nikki, thank you again so much for.
Yeah. Thank you so much for the opportunity. Thank you.
All right. Goodbye, everyone.